Hi everyone. So welcome to day 7 of the Study-a-thon. Today is our first session of the ward rounds, and we have over here our tutor, Dr. Sanjit Bajpai, who's also our Chief Academic Officer. And today we will be discussing the NExT-PG topics from the last 1 week that you guys have learned. So I think we can start it off now. Sir, I'm handing it over to you.
Yeah, thank you, Anna. I wish all of you have been going through a lot of chapters in the coming days, and you have been recalling a lot of things, you have been learning a lot of things. So there have been a lot of material that has been given to you, and you have loaded yourself with a lot of information. Now, today's particular point of interest is that how can you apply what you have collected in the past week into a surrounding such as a hospital setting? So my idea of these ward rounds is that how do you perform, or just say yourself that you are a junior consultant, okay? And you are taking rounds with me in my hospital, and I'm going to give you 25 scenarios today. And those scenarios we will discuss. So the whole matter is that I want a healthy discussion with the students. I want you to participate in this kind of a discussion, because this will help you clear a lot of doubts when you actually relate what you have studied into clinical settings. And this is what NExT is all about. This is what your PG exams is all about. Now, gone are the days when we used to have these one-liner questions. Now you have to actually get integrated into what actually happens in a patient. Okay, so I'll go one question by one question, and I would want your response coming up. Okay, it shouldn't be that I'm telling you the answer. You have to give it a try. And the person who gets the maximum right, or the person who engages themselves maximum, will get the points. As simple as that. Right? So it's a very, very simple game. And I want you all to enjoy and start thinking about how it actually happens in a clinical point of view, or in rather a clinical setting. Okay, so ready, my junior consultants, you are in the ward rounds. I would take you to the first patient that I have for you today. Right, so my first patient is having something related with swallowing. Okay, he's been there in the ward for a very long time, and he's been suffering from something called a stroke, and he's been there. I ask you a question that swallowing is a complex process. You know that it involves signaling between the pharynx as well as the swallowing center in the brainstem. There is something called as a swallowing center. We are all going through it every day of our lives. Now, which of the following structures is critical for determining whether the bolus of food that is small enough to be swallowed? So understand my question here. What important structure is critical here to determine that amount of food is good enough to go inside me or not? Okay, or small enough, or as a checkpoint, I can call it, whether it should go inside me or not. Is it the epiglottis, which is my checkpoint, larynx, palatopharyngeal folds, soft palate, or my upper esophageal sphincter? So which of the following structure do you think plays a very critical role as a checkpoint to determine whether my food is going to be swallowed or not? As simple as that. So I want answers coming up now. Okay, Anna, I want the chat boxes of the students there. And I want you to guys at least attempt of what you think here, because you must have heard about physiology of swallowing. You must have read about what exactly are these structures about, what is happening in there. So in the word, you need to put up these concepts. What happens in swallowing? What is that one critical structure that determines the bolus, whether it is going to go down or not? Anyone wants to have any kind of, you can straight away go forward and write it on the chat box. What do you think is what critical structure is important here? So my patient is suffering from stroke. He might not be having a very good supply over on that structure. So that's why he's not able to carry on that process. That's why he might be aspirating. Aspirating means all the food is going into his lungs. So that is why I don't allow him to swallow. I keep him on a tube through the nose that directly causes the food to flow into the stomach, but I'm not letting him swallow. What is the reason? What is wrong with that critical checkpoint? First, tell me, what is that critical checkpoint? Anyone in the audience who wants to go for it? Arushi, Deepti, Nidhi, Shreya, anyone. So, okay, Arushi has tried epiglottis. Okay, anyone else wants to go with any other answer? Then I would give you a hint. Then I would start generating epiglottis. Okay, Shreya, you want to go? As you said, it's going in the lung. Okay, fine. Right. So you have possibly said the epiglottis. Okay. Again, I'm telling you, it is critical for determining whether a food bolus is small enough. Remember that word, small enough to be swallowed. Anyone? Arushi and Shreya, I'm going with your answers of epiglottis. Anyone wants to attempt anything else? See, feel free. I'm going to correct you if you're wrong. But I want answers from you. This has to be an interactive session from both the sides. Anyone else? Okay, now let me ask both Arushi and Shreya, what exactly does the epiglottis do when you swallow? You can write it on the chat box, or you can even unmute yourself and talk to me. I'll clear each and everything today. This is what the word means. That you have to ask questions so that I clear you off. Okay, what is the role of the epiglottis when you are swallowing? Anyone? You can unmute and you can answer me. Prevents food from entering into not the pharynx, Arushi. It is through the laryngeal inlet. Okay, pharynx is something that we are given. So there are three parts of the pharynx: nasopharynx behind the nose, oropharynx behind in the area behind the oral cavity, and there is something called as laryngopharynx. Right? If I have something going into my laryngopharynx, that has to be prevented and going down inside my trachea. Correct? So the correct would be prevents food to enter inside the laryngeal inlet. Okay, instead of calling it pharynx. Right? So as you know, there is some organ that is here that is called as larynx, and beneath that there is my trachea. So what happens is, suppose if you can see my video, if this is my epiglottis, when the food comes, it falls back like this over my laryngeal inlet. So the food goes behind it into my esophagus. So the exact mechanism of epiglottis is to swing backward to close the larynx during what we eat. Okay, so epiglottis is not right in here. Epiglottis is not the right answer. So what exactly is the right answer? Let me tell you. Palatopharyngeal folds. Okay, so there are two important folds in our oropharynx. Can you tell me what is anterior pillar and posterior pillar? Can anyone know that? Okay, can anyone tell me what is anterior pillar made up of? What is posterior pillar made up of in my oropharynx? See, all of these questions have been taken up from AIMS, PGI, Chandigarh, all of your previous year questions that have come in your All India NET-PG exams. So if you are capable of answering and thinking about them, you are good to go. So can you tell me what exactly is palatopharyngeal fold? Anyone? One, it has a name called as palate. Anything is there in the pharynx. What is this palatopharyngeal fold? Anyone? Anyone? Out of the students, palatopharyngeal fold, anyone wants to try? What is that? Anyone? Shreya, you want to try palatopharyngeal fold? I think you can unmute. Don't worry. Shreya is there. Okay, Arushi, you want to try? What is a palatopharyngeal fold? See, this is where I want to integrate your knowledge of physiology and anatomy, because you need to understand these structures. Anyone? Okay. No idea, Arushi. No problem. No problem. Nidhi? Deepti? Anyone? Okay. So these are two folds behind the tongue. Okay. You know what is a tonsil? You must be seeing a tonsil. Okay. So there is one fold in front of the tonsil that is called as palatoglossal fold. There is one fold behind the tonsil that is called as palatopharyngeal fold. So what happens is, whenever we are eating, okay, these palatopharyngeal folds are like this, and they come to the midline and they close like a slit. So basically, they come together and close like a slit. Okay, right? No problem, Shreya. No problem. So these are on my pharyngeal wall. Whenever I'm eating, they come to the midline. Now, what will happen once they come in the midline? What is the role of them? Once they come in the midline, they will have a very critical role in determining that this in a food can actually go inside or not. Because now they are compressing. I don't want a whole egg to go inside suddenly, right? Otherwise, I can swallow everything. So I need these folds so that whenever I'm swallowing, they will come in the midline like this, and they will form a checkpoint. And they will say that, okay, this is small enough to go inside. Right. So palatopharyngeal folds is the right answer for this. Okay. Remember, this is for determining whether the bolus is small enough to go inside or not whenever I'm initiating a swallow. Okay. Remember that. Okay. So anyone has any doubt in the first question, they can raise their hands here itself. It cannot be larynx, because larynx itself has got vocal cords. They shut during swallowing. It has got no role to do because it is involved in breathing. Palatopharyngeal folds is the right answer. Soft palate cannot be the answer. Why? Because it shuts off. It raises and shuts off the nose during my swallowing. And upper esophageal sphincter is the starting point of my esophagus that has to be dilated enough to swallow. So the only checkpoint that I have to swallow is this palatopharyngeal fold. No doubt? Okay. Now we'll go ahead. Now my second question for you in my ward is this. Okay, so I have a patient in my ward. This particular patient is having symptoms of difficulty in swallowing and he has been referred to a gastroenterologist. So I've referred this patient. He's having difficulty in swallowing. So can anyone tell me here, what is the literal name for difficulty in swallowing? If I am a doctor and if I have to say that a patient is having difficulty in swallowing, what is the medical name for that condition called as? You might get this medical name also sometimes. Can anyone tell me in the chat box? What is the medical name for difficulty in swallowing? Yes, dysphagia. Okay, so dysphagia is IA. Okay, corrected, Arushi. It's the right answer. So phagia means again food. This means not able to swallow. So not able to swallow is called as dysphagia. If I say odynophagia, odyno means pain, painful swallowing. So this patient has difficulty in swallowing or rather dysphagia. Now, the higher tone, so there was an endoscopic examination that was conducted by the gastroenterologist, and he found out that the lower esophageal sphincter is basically the one which has a higher tone. Higher tone means it is very tonic, it is contracted, and it has got a very high tone. That is why it is not letting the food to go down. Now, a fall in which of the following can be the most likely cause for this particular disease? Okay, so what exactly has gone wrong here? Why is the tone very high? Is it because of release of acetylcholine? Or is it because of activity of nitric oxide synthase? Or is it because of secondary peristalsis? Or is it because of phrenic nerve discharge? Okay, so Gopika has tried to be nitric oxide synthase. Okay, anyone else who wants to contradict Gopika here and want to tell any other answer? I'll go one by one, why it is and why it is not. See, this is how the rounds are discussed. So you might find this kind of a patient in your everyday setting. My food is not going inside, did an endoscopy, lower esophagus has got a very high tone. The sphincter is contracted, not letting any food go down into the stomach. What exactly has happened physiologically? Okay, so Gopika, you are saying it is because of enosynthase. Anyone wants to go with any other answer? Any other answer? Anyone? Everybody wants to go with enosynthase? Anyone wants to write? Attempt. Don't worry. If you've got enosynthase, then you can write enosynthase only. Whoever wants to attempt it. I want every one of you to attempt these questions. Then only it will generate that concept inside you. Okay, Arushi, what do you think? Deepti, Nidhi, Sharon, Shreya. Arushi thinks it's B. Okay, again, enosynthase. Anyone else? Anyone else wants to go? Okay, now I would like Gopika to unmute. Gopika, are you there? Gopika, are you there? Don't worry. This is just a very frank and friendly discussion. Arushi, you want to try? You want to unmute? Arushi is there? See, I want you to be wrong. That's why that's where my rounds are. Because tomorrow you would be taking these rounds with your consultants. Okay, anyone wants to attempt it? Okay, let me make things simpler for you. What does acetylcholine do? Let me take the first option. What is acetylcholine and what does it do? Everyone has heard acetylcholine? It's a neurotransmitter. Okay, Arushi is right. It's a neurotransmitter. Okay, can anyone unmute? You want to try Sharon? Sharon is there? Yes. So Sharon, can you unmute yourself for a minute? Because things would be faster than writing. Can participants unmute? Don't worry. Sharon is there? Can't hear you. Anna, are you there?
Yes, sir, I'm here.
Yeah, are the students not able to unmute themselves?
No, sir.
because I think Sharon has also written unmute option is not there. Okay. So yeah, they are not able to unmute, I believe.
Okay, so I'll just take a look.
Yeah, just okay. Till then, I would rather contact you over on the chat box till Anna is fixing this. So acetylcholine is a neurotransmitter. Okay, let me give you this answer. The answer is NO synthase. That is right. Why? First, what is acetylcholine? Acetylcholine is a neurotransmitter for your parasympathetic nervous system. So always remember there are two things: parasympathetic nervous system, sympathetic nervous system. Parasympathetic nervous system means rest and digest. Now, what do you mean by rest and digest? Simply think of me eating a samosa. Okay, so when I'm eating a samosa, what will it do? It will cause peristalsis. More gastric juices will be secreted, more of my intestines will move, and more of my sphincters will work. So what is my acetylcholine doing? Acetylcholine is basically causing my samosa to get digested. So that means it is causing more contractions, right? Okay, so everyone has been unmuted now, right? So acetylcholine is doing that. That means more and more of contractions. Okay, now when it comes to nitric oxide, remember two words in nitric oxide. Wherever you get nitric oxide, it does two things: relaxation as well as vasodilation. So nitric oxide, when it acts on the vessels, it causes vasodilation. When it acts on muscles, it causes relaxation. Together with nitric oxide, there is one more element which causes this relaxation. Can anyone tell me? Gopika, you want to go for it? Can you tell me what exactly one more thing causes your relaxation? Yes.
Vasoactive
Beautiful.
inhibitory peptide.
Yes. Vasoactive intestinal peptide is also from the interneurons that are secreted, right? And it causes things to relax. This is, I'm talking about the innervation that is there in your GIT. Okay. Right. So the right answer is nitric oxide synthase. Always remember two things: dilation as well, relaxation and dilation. So vasodilation and relaxation are two things which nitric oxide synthase does wherever you find this. So if it will act over on the lower esophageal sphincter, it will cause its expansion. Now, can anyone tell me the disease, what has happened in this patient? Why did I send it to a gastroenterologist? What is this disease called as? That is contraction of the lower esophageal sphincter. What is this disease? Can anyone tell me? So if you don't know, this, yes.
Achalasia cardia.
Beautiful. Yes. So I'll give you points on that, Gopika. See, all of you, the more you answer, the more points you are going to get. This is the idea. So she's right. I want everyone to answer like this. Okay. Everyone come up, discuss with me. Achalasia cardia. Cardia means why? This is not the heart. Cardia means cardiac end of the stomach. Achalasia means not able to open. Right? So when the lower esophageal sphincter is too tight and the esophagus is not able to open and put its contents into the stomach, we call that condition as achalasia cardia. And that is basically because of the NO synthase is one of the reasons, not all, but one of the reasons is that the NO synthase activity falls, right? And it is not able to die. Okay, so everyone is clear here, right? Everyone is clear. What does phrenic nerve do? What does phrenic nerve do? You can write it over on the chat box. Anyone can open up and speak. What does phrenic nerve discharge got to do? Anyone? Okay, let me give it to you. Phrenic nerve supplies what? Okay, I'll tell you another clue. If suppose, yes. Yes, somebody told. Phrenic nerve supplies what? Anyone? Yes, diaphragm. Yes, Gopika, you're right. Diaphragm is the area which the phrenic nerve supplies. So phrenic nerve, when it gets damaged, it has not got to do with the internal sphincter. It is more likely causing problems with my external sphincter. So it causes pinching action over on the esophagus. So if it is damaged, then that particular pinching action of my esophagus is gone over by my external crura or my external crus. That is the whole reason for phrenic nerve. But it doesn't produce this kind of achalasia-like picture. Okay, that is why phrenic nerve is not the right answer. I'm talking about the internal lower esophageal sphincter here. Okay, so that is why the answer is NO synthase. Right. Okay. Now I'll move on to the third question of my word rounds, and I want all the students to come in more and more. Okay, now this is interesting. A patient has come to my OPD and that patient is complaining pain in right lower premolar region. Okay, premolar in the teeth region, right? Now the X-ray findings suggested that the pulp of that particular patient has been infected and an abscess has formed in the root of that particular pulp, of that particular teeth. right? The root is infected now. Now the patient is suggested a root canal treatment by the dental doctor I sent the patient to in order to save the teeth. Now, while undergoing the treatment of root canal, it was difficult to manage the salivary secretion of the patient in order to for the dentist and carry on the treatment, because it was too much of saliva in the mouth when the dentist was doing his procedure. Now, which of the following was supposed to be the characteristics of saliva during the treatment? Now think here, okay? See, I always believe the bigger the question is, the more information you have. And the more information you have, the easier the question becomes. Because I've told you so many things. And this is what your time wastage happens. Okay, so see, all of this story is not important. The story is very simple, that a person has gone to get a dental treatment done. During that dental treatment, there is a lot of saliva in the mouth. What do you think is the characteristic of saliva during this treatment? Now, is it that the patient is having hypertonic saliva with rate of secretion less than 500 ml a day? Hypotonic saliva with rate of secretion more than 500 ml a day? Hypertonic saliva with rate of secretion less than 1500 ml a day? Or hypotonic saliva with rate of secretion more than 1500 ml a day? This looks very difficult question, but this is the easiest to answer. Can anyone attempt this? Always go retrograde to your knowledge, whatever you're getting. And I'm going to tell you four or five important facts in every question. D. Shreya says D. Okay, can I have Shreya over on the mic, please?
Yes, sir.
Yes, Shreya. So you told D, and what makes you think it is D?
So usually the secretion of the saliva per day is about 0.5 liter to 1.5 liter.
Great. That means around 1000 to 1500 ml, we can say. Okay, that is the right answer. So the first point, what she said is right. 1000 to 1500 ml per day is our normal rate of secretion of saliva. Correct? Okay. Now, second point, what do you think? That is it hypertonic or hypotonic?
It's hypotonic.
It is always hypotonic in respect to plasma, right? Yes. So what exactly are the two options already went? So if my normal rate, now this answer you can even attempt, even if you don't know whether saliva is hypertonic or hypotonic. Why? Because if my resting rate of secretion of saliva is around 1000 ml to 1500 ml, when I will do a dental procedure, my saliva will come out more. Correct? So my rate of secretion will be more than 1500 ml in a day. As simple as that. And to complete that answer, it is always hypotonic in respect to my plasma. So Shreya is right. D is the right answer. And why it is happening more, Shreya, can you tell? Why it is causing more salivation?
No, sir.
Because of external stimulus. So the person is having a dental treatment going on. There is a drill inside. There is something called they're using their instruments inside. So obviously there will be, because of that external stimulus, they will lead to more secretions. So automatically it will become more than 1500 ml a day. As simple as that. Right? So you are right. Hypotonic saliva with rate of secretion more than 1500 ml. Noted down, normal salivary secretions are about 1000 to 1500 ml per day. And dental treatments, why do they cause more salivation? Because continuously they are using their drills, continuously they are cotton dabbing over on the root pulp. So that is the reason it causes more salivation to happen. Right? These are the important things. And it is hypotonic. Hypo. Okay, always remember saliva is hypotonic in respect to the plasma. Got it? Any particular confusion, you can raise your hands. Any confusion. Okay, so D is the right answer and Shreya has got it right. Okay, now I move on to the fourth question and my fourth word round. Yes, it is here. So this is very simple. Whatever I discussed previously, you can easily make out from this. In a research study on a salivary secretion, the researcher was supposed to record the salivary secretion among the subjects after providing different situations. All the subjects had gone through following conditions. Which of these conditions could be associated with the lowest, okay, this is the catch point, lowest rate of secretion of saliva in the same subject? Where do you think saliva will be the lowest? Is it after smelling a nauseating odor, having a chewing gum, fear and anxiety, and undergoing a mock dental treatment? Now tell me, after what do you think the lowest rate of salivary secretion will be there? This is in our general everyday life. See, all questions are not medically based. There are some questions which are general, very, very general. So what do you think will be your least? Yes, Arushi has answered the right option. Okay, Gopika has also answered it right. Arushi was first to answer. Arushi, can I have you over on the mic, please? Arushi is there? Yes, sympathetic reaction. Absolutely. Right? So fear and anxiety releases a lot of sympathetic overdrive. What has sympathetic overdrive got to do? Flight and fright. So flight and fright. So what happens during my flight and fright? Suppose a tiger came next to you. What will you do? You will just suddenly jump and you will start running. When you will start running, what all effects will you have? You will get what? You will get a fear, right? You will get anxiety. Your mouth will become suddenly dry. Why? Because your rest and digest system has gone down, right? So your salivary secretions will also go down. So in all of these circumstances, wherever there is a fear and anxiety, you will always have decreased salivary secretions. You understood? See, very, very simple. So what we call in Hindi as muh sukta hai, when we start running, this is what it is, right? Suddenly when you have fear of anything, in your exams, you will have a fear, right? Your mouth will suddenly become dry. You will call the person and please give me some water. As simple as that. So as simple as that, when you smell a nauseating odor, it will directly cause reactions over in your mouth to start salivating. Similarly, when you have a chewing gum, smooth surfaces start having secretions more. So a chewing gum, you must have seen that a chewing gum is very glossy and smooth over it. So this is also a research that has been done that whenever you chew something very smooth, like a toffee or a chewing gum, that also causes a lot of secretions because it has smooth surfaces. Fear and anxiety reduces. And as I told you, dental treatment also increases because they put a lot of cotton, they put a lot of their instruments inside, which stimulates salivary secretion. Okay, got the idea? Anyone has any kind of doubts in the word round still now? You can drop over your questions in the chat box. I will read it and I'll try to answer them as soon as possible. Okay, fine. I'll move on to the next question. And I want, yes, Navera, you also answered it right. It is C. Sympathetic reaction, it's the same thing. Okay, now I move on to the fifth question in here. Right, now this is something which is a little difficult to understand, but it's easy at the same time if you get it. I've already discussed about this patient. A patient, this is the same patient I sent it for gastroenterology. And now that patient is having complaints of difficulty in swallowing. He's having heartburn, that means acidity in simple terms, and he is having bad smelling breath. Now, can anyone tell me in the chat box, what do you mean by bad smelling breath? What do you call the medical term for bad smelling breath is called as? Okay, anyone? The literal medical term for bad smell or foul odor in your breath. So now we have to start speaking in our medical languages. We have a dictionary, right? And I told you when I was giving you orientation programs that literal terms need to be understood. So what do you mean by bad smelling breath? Anyone in the chat box? Can anyone tell me what is the literal term or that symptom called as? Like dysphagia is difficulty in swallowing. So bad smell in your breath is called as halitosis. Halitosis, halitosis. Yes. So that is right, Shreya. Halitosis is the right answer. Right. So now this person is having acidity issues and bad smell or halitosis. Now his esophageal manometry was done. What do you mean by esophageal manometry? Is nothing. It is checking the pressures over in your esophagus when it is contracting and relaxing. That's what is called as esophageal manometry. And this was performed during swallowing. Now, at the end of swallowing, the finding on the esophageal manometry they found out was most likely to be which parameter? Okay, so which of the following parameters do you think that this esophageal manometry will give you that? Okay, so this patient is having acidity issues. He's having difficulty in swallowing. The first thing that comes in my mind is what? That when the food is going into the esophagus is getting contracted, but it is not relaxing for letting the food go into the stomach. See, it is a game of peristalsis, right? When the food is going into my lower esophagus sphincter relaxes and all the food goes into my stomach. Then it contracts back again. This is the normal thing that is happening. Now, when this patient came in difficulty in swallowing, we did something called as pressure monitoring or esophageal manometry. So what is the likely finding that you will find in this manometry? 1. A dilated esophagus with subatmospheric pressure. A dilated esophagus with higher atmospheric pressure. Normally distended esophagus with higher atmospheric pressure, or normally distended esophagus with subatmospheric pressure. Now, this is a confusing question, but it is very simple if you understand this question. It is a very simple question. Can anyone try this? I'll give you bonus points if you get this question. Anyone? You want to try? At least give it a try. See, I'm not going to punish you if you don't answer it right. But at least I want to try from you so that you generate this kind of thinking of what happens in your day-to-day life. Because we are not going to deal with physiology of swallowing in patients. We are going to deal with clinical scenarios, right? Where we have to put in the knowledge of our anatomy and physiology. Anyone, whatever is the right answer. Array, give it, just write it off. A, B, C, D, anything you write. Anything, whatever you wish. If you even don't know the answer, you put that tukka. Chalo, let it be. B is the right answer, or A is the right answer. Okay, Karunamai is answering is A, right. So, Karunamai, can I? Okay, Sharon is answering B. Anyone for C and D? Anyone for C and D? D, Gopika. Okay, anyone else? Anyone else wants to try? See, I'm going to get you biochemistry questions soon. I'm still in your physiology of swallowing. I'll give you biochemistry also. I'll give you anatomy questions of abdominal wall also soon. But okay, Arushi also thinks it's D. Right. Now, let me have, because Karunamai was the first to answer, let me have Karunamai. Karunamai is there? Karunamai, can you unmute? Don't worry. Are you able to unmute? Oh, she's not able to unmute. I think there's a some problem is there in unmuting. Anna, if you can solve the this thing out, that they're not able to unmute.
So, but for Karnamai, I've unmuted her.
Okay, yes, Karnamai is there now. Karnamai, can you hear me? No, she's not able to. Okay. Okay, we'll sort it out. Till then, I would tell what exactly is wrong here. Okay. If I think Anna, if you can help her out in unmuting, it'll be.
Yes, sir. I'm checking that, sir.
Yeah. So, what exactly happened in this patient? Now think. Food went inside, not able to swallow. That means what? When the food went inside, suppose this is the lumen of the tube. Okay. Food went inside, the lower esophageal sphincter is closed. It is not able to open. We already called that condition achalasia cardia. Correct? It is not able to go inside the stomach. So food is getting collected in the esophagus. So what is happening? Once food is getting collected in the esophagus, the esophagus lumen is getting distended and distended and dilated and dilated and dilated. Correct? Because nothing is going down into the stomach. So the food is all getting collected and my esophagus is getting dilated. That is my first thing. So in all these options, only the first two options click into dilated esophagus, right? Because food is not going down. So it cannot be normally distended. It has to be dilated because food has not gone down. Correct? Now, what is the second part? When the food will not able to go down, what will happen to the pressure in this area? It will be higher than the pressure that is outside me or higher than my atmospheric pressure. Simple, right? Whenever there is a lot of food inside in this area, the pressure will keep on getting higher and higher. And at one particular point of time, it will cross over my atmospheric pressure outside. So what will be the right answer finally here? Now write down your right answers. What will be the right answer? B. Simple. Now you understood the logic, right? So a dilated is, yes. What is the difference? So what is difference? Dilation and distension. See, dilation and distension is the same thing. Don't confuse in this. Distension means again increasing in size. Dilation is also increasing in size. Whenever we talk about luminal structures like stomach or intestines, we usually use the term distension. Okay, so I would rather correct this. I would say distended esophagus would be a better thing to say. But we have kept this a question because this was asked in your previous year aims. So we have kept it as it is here so that you get to know what exactly the question was. But a distended esophagus is the same thing. Okay, Arushi, don't get confused here. So are all the students understanding what I'm saying? You're understanding? So this is what exactly you need to follow. Okay, now how will you catch this patient that this patient's lower esophagus is not getting distended or not getting opened up? Is because all the food, the first point itself says difficulty in swallowing. That is why his lower sphincter is not opening. That is why nothing is going down. Heartburn, why? Because all that is there, all the food that has been collected is coming back into his esophagus. So he's having that kind of an acidity, right? What we call as heartburn. And when this acid comes above and the food comes above, it will coat your tongue and that tongue will get coated and produce a bad breath. See, all of things are related. It's regurgitation, what we call it. Correct? So they will have a very bad breath. Now you understand why we do esophageal manometry in these patients. Now can you clinically understand that? Okay, can I get a yes from students? And then I will be able to move forward onto my next word round question. Okay, fine, Sharon, thank you. So now I suppose everyone is has gotten the right answer. Okay, fine. Now I move on to this. Yes, now I move on to the sixth question of my word round. Which of the following is the feature of autonomic control of salivary secretion? Again, autonomic has got sympathetic, parasympathetic. Is it the postganglionic fibers of sympathetic supply start from superior cervical ganglion? This is straightforward if you remember your autonomic nervous system supply of salivary secretion. Is it parasympathetic supply depresses the salivary secretion? Is it sympathetic supply is more prominently increasing the secretion over parasympathetic, or parasympathetic supply originates from superior and inferior salivatory nuclei? This is very, very simple. Just think what I'm telling you. Out of which is the feature of autonomic nervous system. Now, autonomic nervous system has got parasympathetic and sympathetic. So what sympathetic does? Decrease saliva. What parasympathetic does? Increase saliva. So what do you think in this is the right answer? Anyone who wants to attempt this? This is your PGI Chandigarh question. Anyone who wants to attempt this? Yes, any student? Anyone? Come on. I want Anjali, Arushi, Deepti, Sharon, Shreya, Nidhi, anyone? Karunamai, A or D? Okay, Arushi thinks it's A or it is D. Anyone else wants to try? See, I'm giving you a hint. I'll give you points. The more you earn, the more you learn. This is what the logic here is. Okay. What exactly has happened? A or D? Okay. So now let me revise your autonomic salivary secretion. Sympathetic, when I call it, my saliva reduces. Because what happens in sympathetic? My acinar cells are there in my salivary glands. Those acinar cells will not secrete enough saliva. Simple. So it is depressing my function of salivary secretion. How does my sympathetic work? It is from the fibers from my superior cervical ganglion, which are innervating my nerve endings. And what is it releasing? It is releasing neurotransmitters which are sympathetic, which are what? Which are noradrenaline, adrenaline. These are my sympathetic neurons, right? Sympathetic neurotransmitters. They are depressing it. So the postganglionic fibers that are coming from the sympathetic nervous system are coming from the superior cervical ganglion. And they are doing what? They are depressing my salivary secretion. A. When I talk about parasympathetic, all my innervation is carried by two nerves, 9 and 7. That is facial and glossopharyngeal. All of these nerves carry my impulse to my centers in the brain, and they finally cause increase in secretion from my acinar cells by release of acetylcholine. Acetylcholine acts on which receptors? Muscarinic receptors. Which type of muscarinic receptors? M3 type of muscarinic receptors. Simple. So now what do you think is the right answer out of this? I've revised all of your autonomic system here. What do you think is now the right answer? Sympathetic supply decreases saliva, comes from, you can write it down. It comes from where? Superior cervical ganglion. Simple. So when it comes to S sympathetic, S superior cervical ganglion. Parasympathetic, 9 and 7th nerve. Itna yaad rakho, that is enough. Okay, now you see these options. Postganglionic fibers of sympathetic supply are from superior cervical ganglion, right answer. Parasympathetic depresses salivary secretion, cannot happen because parasympathetic increases the salivary secretion. Sympathetic supply is more prominently increasing the secretion, no. Sympathetic supply decreases the secretion. Parasympathetic supply originates from superior and inferior salivatory nuclei, no. So now you understood. As simple as that, we have got only one option left. That postganglionic fibers of sympathetic supply cause basically the innervate from the superior cervical ganglion. Now you got the right answer. Anyone has a doubt in this? Okay. If you guys don't remember, why is D not correct? Because parasympathetic supply originates from the superior and inferior salivatory nuclei. It's partially correct. See, I'm talking about 9 and 7. 9 is coming from the inferior salivatory nuclei. What about 7? right? So if I talk about inferior salivatory nuclei itself only, that might be partially right, but not both. That is why strongly I believe that only A would be the right answer, right? Right, Arushi? I think you got the answer. Okay, fine. So now I would move on to the next question, and I want more students to come in. See, this is not information loading. I want you to participate. See, wards are supposed to be two ways. Okay, this is how wards will be conducted later on also. This is what the whole idea about clinical scenarios is. This is what the hospital setting looks like. Okay, fine. Okay, now I want other students to come in as well. 64 years old woman is admitted to our ward, consulted to a GI physician regarding a problem of heartburn. That means she has acidity. Now, she also reported the feeling of regurgitation from the stomach and some acidic taste in the mouth. Something we have done behind also. Now, all think now. Regurgitation from the stomach, not from the esophagus, from the stomach. Okay. On the examination of gastric emptying, 80% of meal was retained from the stomach at the end of 4 hours after the meal, which shows extremely delayed emptying. Now that there is something that it is there is food in the stomach, but it is not able to come out, right? It is delayed emptying. Okay, 4 hours have been there that the stomach still has food. Patient had reported temporary relief after giving something called as proton pump inhibitors. You must have heard in your regular life, Pantop, okay, esomeprazole, omeprazole. You must have kept it in your homes also, right? Pan-D or Pan-40, your ranitidine. What do you call different these terms, right? These brands that come. These are all proton pump inhibitors, right? They basically decrease the acidic secretion. Yes, Arushi knows Pan-D. That is also a proton pump inhibitor. So what would be the probable diagnosis in this patient? What can you think? Okay, Gopika has told peptic ulcer. What do you think? That there is food gone inside into the stomach, no problem. But the food is retained for a very long time in the stomach and not able to go out. It is getting retained. And then it is causing that reflux to come back, and it is producing again acidity. So that reflux is happening. Again, I'm giving you a hint. Yes, Nidhi, I think you're getting it. Reflux is happening. So what is happening with the reflux? What is that called as? That's called as GERD, what we can call as gastroesophageal reflux disease. Simple, GERD, right? So what is happening in this patient? Think now. This patient is having some GI issue. This is very common with us also. Suppose we ate chola bhaturas in the afternoon, right? And after eating those chola bhaturas are not getting digested and they are not going out into my intestines, and they are again feeling me very heavy. Okay, now this is 64 years. She already has a very weak peristaltic activity left. So now she has got chola bhaturas in her stomach, not able to digest, and she says, I'm having a lot of burps. I'm having a lot of acidity. What is happening? The lower esophageal sphincter is open now. It's relaxed. So when the lower esophageal sphincter will relax, all my food contents will come up. And it will come and cause a lot of abrasions and erosions of those acidic contents over in my esophageal lining. That will produce symptoms, and that is called as GERD. Why it cannot be achalasia? Achalasia, I told you, is because the lower esophageal sphincter is too tight. So food cannot go down. Here, food has already gone down, so it cannot be achalasia. Peptic ulcer doesn't produce these kind of symptoms. There can be these kind of symptoms, but delayed emptying, mostly it is because of GERD. Duodenal also cannot be. If I'm giving you these options, GERD is the best option that fits in. Right? That is why they have also told proton pump inhibitors, because that is the treatment of choice for GERD. That is what the situations are. These are the situations that you will be given in exams. Okay. So now everyone is understood. Anyone who doesn't understood till now, what exactly has happened? The lower esophageal sphincter of this lady is dilated. It is not constricting. So all the contents of the stomach are coming up back into the esophagus, and she's having a heartburn. That's simple as that. Okay, for that we are treating it. So everybody is understood? Should I move ahead? Okay, can I get a thumbs up from the students? Anyone who has not understood can raise their hands and they can answer. Okay, fine, great. Okay, right. So now move on to the next one. This is very, very simple. I won't take a long time on this, otherwise you guys will be hanging around. During the pharyngeal phase of swallowing, the primary mechanism of deglutition apnea is linked to which thing? Deglutition apnea. Now, just see this word. Deglutition means swallowing. Apnea means cessation of breathing. So I cannot breathe when I'm swallowing. As simple as that. So deglutition apnea, the primary mechanism is because of what? What do you think is because of? Is it because of the backward swing of epiglottis? Is it because of adduction of vocal cords? Is it because of elevation of the pharynx? And is it because of contraction of suprahyoid muscles? This is a trick question. Again, Shreya, it is a trick question. If I give you two options, you're partially right. Backward swing of the epiglottis occurs, I already told you, in order to shut your larynx. But what is more important in the larynx to close in order to cause complete cessation of breathing? What is more important to happen? What is one thing that has to happen in my larynx in order so that nothing goes down in my trachea? Yes, absolutely, Arushi. My vocal cords have to shut. Now see, my vocal cords are like V shape. They are like my fingers. When I breathe, my vocal cords go apart and I'm breathing. When I talk, these vocal cords shut. So when I say yes, they shut, breathe, they open. So whenever I'm having any kind of deglutition or whenever I'm having a swallowing, when my food is going down, my epiglottis will go back and it will shut my laryngeal inlet like this. And at the same time, my vocal cords will also shut together so that nothing goes down in my trachea. That is called as adduction. Adduction means coming together. Abduction means going away. So the primary mechanism of deglutition apnea, if I tell you two options between backward swing of epiglottis and adduction of vocal cords will be the first option, because that is completely seizing my breathing. Okay, I'm not able to do that. Okay, that is why sometimes during swallowing you can talk. Okay, you can create a voice. Why? Because vocal cords are shutting. You can still create a voice in that, but you cannot breathe. Right? That's called as deglutition apnea. Everybody understood? Understood, everyone? Why this is happening? Right? Okay. So now I will move on to the next question. Anything, any queries, drop on. I'll stop there. Okay. Right. Now I move on to the 9th question here. This is also very simple. Now I'm not going to have any kind of hints in this because I have already moved on from a lot of things telling you. 57-year-old male presented with dry mouth, impaired speech, chewing and swallowing. He's not able to chew, swallow, and he also has bad speech. He's not able to speak well. He has a very dry mouth because of that. See, saliva is very important for speech, chewing, and swallowing. Since the last 6 years, he was on the medication of osteoarthritis. He reported that he had to sip fluids while having the meals frequently. In order to eat, he had to sip again and again. Detailed assessment of the patient suggested that he was suffering from drug-induced xerostomia. What is xerostomia? Can anyone tell me on the chat box? Quick. Fatafat, can anyone tell me? What do you mean by xerostomia? Stoma means what? Yes, exactly. See, the word itself is Greek. Stoma means mouth, zero means dry mouth. Simple, Gopika, right? You've got the right answer. So xerostomia means dry mouth. So because of the osteoarthritis treatment, this patient had dry mouth. The whole story is till now this much. Okay. This is the following least likely condition to be associated with the case. See, what can not happen with dry mouth? As simple as that. The rest of all is a story, just to confuse you. So is it oral ulcerations, regurgitation of food, loose denture, candidiasis? Least likely, what do you think can happen to this patient because of dry mouth? This is very, very easy. Think of your general life. Okay, Gopika says candidiasis. Anyone? Come on, other students also. What do you think, Anjali, Deepti, Karunamai, Nidhi, Sharon, Shreya? Anyone? Anyone wants to go ahead with any of these? What do you think cannot happen in this patient? See, if I just put yourself on this patient side. You have a dry mouth. What can least likely happen to you if you have a dry mouth? Can you have an ulcer? Can you have acidity? Can you have a denture which is having problems? Can you have candidiasis? Candidiasis means what? Anyone knows? Okay, I'm going to give Gopika and Arushi plus points because they are very much participating. Yes, Sharon has now come. Fungal. Yes, absolutely. Fungal infection of the oral cavity. Yes, that is called as candidiasis. Candida albicans, right? Candida is one of the things that causes these fungal infections, which are very, very common in people with dry mouths. See, what exactly is saliva doing? Saliva has got an antibacterial activity. It has got a very important role to fight against infection, right? It has got lysozymes. So if I have a dry mouth, I will be prone to such infections. So candidiasis can happen in this patient, right? Right? So you guys have answered candidiasis. That can happen in that patient. The patient can have oral ulcers also. You must have seen, you go to your exams and suddenly you come with small ulcers in your mouth. That exam ulcer is called as aphthous ulcer. Very common. Why does that happen? Because you don't drink a lot of water. You're in a lot of stress. Saliva reduces. That's why you have these small ulcers in your mouth, right? What cannot happen? Even loose dentures. Loose dentures. See, loose dentures is what? Saliva is required. Saliva is required for dentures to go and fit in. It needs that lubrication, right? Otherwise, dentures will have a lot of soreness that will be present. Absolutely, regurgitation cannot happen. If I have a dry mouth, has it got to do with my stomach and esophagus? Simple. Think. These are very, very simple questions. So regurgitation of food, yes, Gopika, that is the right answer. Because in no way regurgitation is associated with my oral cavity here, right? Only regurgitation can produce a bad breath if it coats my tongue. That's the only thing it can do. Everyone clear now? Got the answer? So what cannot happen is regurgitation of food. Simple? Okay, no confusions. Can I get a thumbs up on this? That everyone has understood? And I'll move forward with my next question that is coming up. I believe you guys have read a lot of anatomy and biochemistry by now. See, this is how you have to get inside that particular logic, why things are happening. Okay, now let me move on to another important question. 56-year-old patient came to the medicine OPD with complaints of passage of bulky, foul-smelling stool, which is difficult to flush. Now, this patient went to the bathroom in the morning. He's not able to flush out his stool. It is very foul-smelling and it is bulky. Now, stool examination was sent and it showed unsplit fat. Which of the following condition is most likely to cause Crohn's disease, bile duct obstruction, pancreatic insufficiency, or surgical resection of the intestines? Gopika has answered it very well right in the beginning. Anyone wants to counter on that? Anyone? Arushi think it's B, bile duct obstruction. Anyone else? See, this is how you have to think. You have to think now. Come on. Anyone? Where are the rest? Come on, students. Who are for C, who are for B, or who are for A or D? Anyone for C? How many of you think it's C? Anjali thinks it's B. Okay. C. Anyone for C? Which was Gopika's answer. Anyone for A? Crohn's disease. Anyone for surgical resection of intestines? So this much you have understood, that the patient is not able to flush. Very foul smelling stool means it is bulky and it has a lot of fat in it, right? So what is that called as? Very rightly said, that is called, Sharon is saying C. It is called as steatorrhea. Steatorrhea means fat in stools. Okay. Steatos means fat. Now, if you've got a lot of fat in your stool, why is that fat coming? Because of the fact that there is a very important enzyme called as pancreatic lipase, which is insufficiently secreted, and it is not splitting my fats in order to in smaller amounts. So it is not getting absorbed. See, a whole chunk of fat cannot get absorbed through my intestines. It needs to get into small components like free fatty acids, right? So if it is not breaking down into fatty acids, it will not get absorbed into those forms, right? So what does that? Who is that enzyme which is produced? Who does that? Pancreatic lipase. Pancreatic lipase is secreted in which part of the duodenum? Which part of the duodenum? Anyone? Where does my pancreatic duct open? Chalo, I'll give you a hint. Where does my pancreatic duct open into? Anyone? Second part of duodenum, absolutely. So second part of duodenum, my pancreatic ducts open into. And pancreas has got two important functions, endocrine, exocrine. Endocrine has got to do with important hormones like insulin, glucagon. Exocrine function releases enzymes. And these enzymes are just example as pancreatic lipase. They basically come out at the second part of the duodenum and they cause a dissolution of our fat, which is very, very important. So if a patient is suffering from pancreatic insufficiency, these lipase activities will be very less. So if lipase is very less, they will not get that much fat breakdown. Fat is not getting broken down. It will come out in the stools and it will become steatorrhea. Simple. That's why we have used the term unsplit fat. It is not getting split. Okay. Now, why are the other options not correct? Crohn's disease, not specifically, because Crohn's disease is basically a chronic inflammatory bowel disease that mostly affects your ileum. Okay. So this is mostly happening in the second part of duodenum or the small intestines, not in the terminal part. So the terminal ileum is mostly concentrated for Crohn's disease. That's why it is not the right answer. Bile duct obstruction, not got to do. Bile duct is finally joining my pancreatic duct in order to form a common pancreatic duct, and it is opening in the ampulla of Vater, right? So that is what the important part is, and the surgical resection of intestines. I think Janice ma'am wants to come inside. Yes, Janice ma'am, you can give your insights, please, because she has been taking your classes and she has definitely taught you all of this.
Good evening, everyone. As you can see, the options that are listed over here are all causes for steatorrhea. Now, the thing is over here in the case that you can see, there's presence of unsplit fat. Now, in steatorrhea, you can have both presence of split fat and unsplit fat. So one thing you have to remember, the causes of steatorrhea could be either, there could be, as Sanchit sir has already mentioned, it could be a deficiency of the digestive enzyme, that is pancreatic lipase, that is released from the pancreas. So some disorder of the pancreas that could lead to a decrease in the digestive enzymes. So that could be one cause. The second cause would be the deficiency of bile salts as such. Bile salts are not being secreted into the second part of the duodenum. That would happen in case of obstruction, bile duct obstruction. So again, that could be a cause for presence of steatorrhea. And the third, bile salts are required for the, emulsification process and mixed micelle formation. All these are important processes that are required in the absorption of fat. And lastly, any disorders of the intestine, because you know that most of the nutrients are absorbed through the intestine. So any disorders of the intestine, it could be inflammation, as in you can see that in Crohn's disease also. And then even surgical resection of the intestine, where parts of the intestine is removed. So again, the intestines are not available for the absorption process. So all these causes would lead to steatorrhea. But the question here, again, as you can see in the case, it says the presence of unsplit fat. So in case of pancreatic insufficiency, you will find unsplit fat because of the deficiency of the enzyme, which is not splitting the fat at all. Okay, in case of pancreatic insufficiency, the other causes would lead to the presence of split fat in steatorrhea. That is seen in Crohn's disease, bile duct obstruction, and surgical resection of intestine.
And they can also confuse you by giving some pancreatic condition. They might call cystic fibrosis. They might say that there is pancreatitis or pancreatic carcinomas. So don't get confused. By the end, if there is any pathology in the pancreas, it will lead to pancreatic insufficiency. Okay, so they can confuse you with such terminologies of pancreas also. Okay, so don't get confused. They will all lead to pancreatic insufficiency, which will finally lead to this particular cause of steatorrhea. Right? Okay, so I think thank you, Janice ma'am, for putting up a very important insight. And
thank you.
This is what this is what collaboratively you have to understand what exactly these diseases mean and how they are producing. Right? Now we'll move on to the next question, and now I am into the segment of Janice ma'am. So I will want her to give some insights about these questions as well as to how things are happening. Right. So now I think get ready with your biochemistry, guys. 65-year-old male patient diagnosed with chronic pancreatitis. See, whatever I was telling has come now. Now this patient has chronic pancreatitis, has come with complaints of passage of bulky, foul-smelling stool which floats in pan and difficult to flush. Same thing. The treating physician suspects it's steatorrhea. Which of the following investigations would not be relevant in confirming? What do you think is not there in confirming steatorrhea? Stool microscopy with Sudan black, fecal elastase estimation, C13 mixed triglyceride test, or serum triglycerides? What do you think is not there? This is something that has been asked in INI-CET recently. right? So what exactly do you think is not going to be very useful? Because it is stool coming out, stool has fat. So what do you think is not very important as an investigation? Anyone who wants to try this? Anyone? Okay, how many of are everyone okay with A? Sharon wants C. Okay, C. Anyone who wants to say Sudan black stain stool microscopy? Anyone? What does fat stain with? Fat stains with what? Tell me a dye of fat. Anyone? What is a fat staining dye? This you must have done a lot of times. Karunamai, Nidhi, Dipti, Anjali. What is the stain for fat? The stain for fat is Sudan black. So remember that. Sudan black stains fat. Okay, always remember that. This will be asked you 100 times. What does fat stain from? Sudan black will always be there. Okay, so Sudan black is one of the stains for fat. So definitely stool microscopy will stain with Sudan black because they already have fat. First option cannot be right. Okay. Now, second is fecal elastase estimation. I'll tell you, elastase is another enzyme that is secreted from the pancreas. Okay, this is also important for digestion of your carbohydrates, proteins, and fats. It's very important. So if suppose your pancreas are working very nicely, your elastase will be secreted and things will get digested. If pancreas are not working fine, elastase will be less in amount. So fecal elastase test or estimation is very important to assess whether the patient is having pancreatic insufficiency or not. Okay, so this again cannot be the right answer. Third is C13 mixed triglyceride test. This is a radioisotope test, which is again now found to be very sensitive. So what they do is they have something called as a C13, a carbon isotope, which they mix in a fat diet and they feed it to the patient. And then through a breath analyzer, they try to assess how much of that has actually degraded. Okay, so this is one of the most sensitive tests nowadays that they do. C13 mixed triglyceride test. You can also name it as C13 mixed triglyceride breath test. What they do nowadays for pancreatic insufficiency, they basically see how much the radioisotope has been cut down after it gets down, and they estimate it. Serum triglycerides have got to do nothing. They are in my serum, right? I can do nothing with them. They will be the same thing. Even if my triglycerides are coming in fat, my serum triglycerides are not going to go above or below. As simple as that. Now you understand. See, serum means blood, right? You have to take out blood. So what is the role of a blood investigation in steatoria? As simple as that. Right? Understood, everyone? Anyone has a doubt on this? On this particular thing? Anyone? So the right answer here would be serum triglycerides. Okay? Fine? Right. Now I'll go ahead with, again, Janice ma'am's question. Yes. Desaturase enzyme is involved in. So now I won't take the options. This should be on your fingertips, guys. What does desaturase do? Janice ma'am has taught you that. What does desaturase do? So D means cutting off. It has got something related to dehydrogenation reaction. Saturase. Now see, what does it cut down? Does it cut down unsaturated fatty acid to saturated fatty acid, or convert saturated fatty acid to unsaturated fatty acid, or it converts aliphatic fatty acids to cyclic fatty acids, or does it convert cyclic fatty acids to aliphatic fatty acids? So these are all confusing terms. Simply see the name. What is there? D and saturase. What will it do? What will it convert? Gopika says A. Anyone else? Karna may say B. Absolutely, Karna may. That's the right answer. Now see, desaturase. The name itself says D means cut off, cutting it. So when this is a particular enzyme that cuts down or converts saturated fatty acids to unsaturated fatty acids, right? So what exactly it is doing? Saturated fatty acids to unsaturated fatty acids, once it's converting, it's adding the double bonds to carbons once it's converting it, which the saturated fatty acids doesn't have. That is one of the differences. It is adding the double bonds between carbons in unsaturated fatty acids. Now, can you tell me, is butter a saturated fatty acid or an unsaturated fatty acid? Okay, write down in the chat box. What is butter? And ghee, what you eat. What is that? Saturated or unsaturated? Now, whenever you're putting a butter on your toast, no, always remember desaturase. Okay. So what is exactly that butter having? Is it saturated or unsaturated? Butter, ghee, whatever you have, solidified fats, dalda. What is that? Saturated or unsaturated? Come on, write it over on the chat box. Any one of you. What are those? Okay, then what is vegetable oil that you put inside? Liquid vegetable oils that you have. Are they saturated or unsaturated? See, this is the concept. Butter, all these milk products, ghee, they are all saturated fatty acids. They are all bad for our health. That is why people get atherosclerosis, right? They eat a lot of butter, they eat a lot of ghee. They are rich in very saturated fatty acids, right? Unsaturated fatty acids are all our vegetable oils, right? They're not as harmful as saturated fatty acids. Now you're understanding the difference. The difference between their compounds is that it's basically having double bonds between carbon and unsaturated fatty acids. And unfortunately, it is not there in saturated fatty acids. Understood? So desaturase is the enzyme. Satu, always remember, this is always got to do saturated. So it is breaking that saturated fatty acid into unsaturated fatty acid. That's the function of desaturase. All are clear now? What desaturase does? Clear? Everyone? Okay, fine. Now I'll move on ahead. My next question. Acetyl-CoA carboxylase is a rate-limiting enzyme for de novo synthesis. So this de novo synthesis, I'm talking about fatty acid synthesis. So de novo fatty acid synthesis, in that acetyl-CoA carboxylase is a rate-limiting enzyme, and it causes a conversion of acetyl-CoA to. Karname is very, very fast to answer. Anyone wants to change that answer? First step of fatty acid synthesis. So de novo synthesis is something that is happening for fatty acid generation. Fatty acid synthesis are it's required in fatty acids are required for a lot of things in our body for energy purposes. So de novo synthesis happens in the cytosol of the cell. So in the de novo synthesis, the first step of acetyl-CoA converting into what is done by this acetyl-CoA carboxylase is B or C, Karunamai? I think I have two options from you, B or C. So yes, it's C. So malonyl-CoA. So don't remember, this is a very, very hit question. Acetyl-CoA carboxylase is a rate-limiting enzyme, and it is dependent on one vitamin also, that is biotin dependent. So this is a biotin dependent rate-limiting enzyme which converts acetyl-CoA to malonyl-CoA in de novo synthesis of fatty acid. Okay, so this is very, 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 very important. Very, very hit question. Okay, note it down. Note it down in your papers. This has come multiple times in your vivas as well as in your MCQs also. Okay, fine. I'll go ahead. This is a very straightforward question. Right. Now, which of the following statements are true regarding fatty acid synthase complex? This type of question you find in PGI. Okay, in your INI CET. Now, so what exactly they do is they give you multiple options, and it is not like that they would have one option which is correct. You can answer 4 or 3 or 4 also can be correct. So unless and until you tick all 4 or 3 or 2, you will not get the right answer. So how many of you think is right in here out of these? So there is a fatty acid synthase complex. It is a complex, okay, of enzymes that have got 3 important functions of condensation, reduction, and releasing. Okay, this particular complex has multiple enzymes in it, right? And they have got certain roles of condensation, reduction, and releasing. Now, what do you think are true regarding fatty acid synthase complex? Is fatty acid synthase a multi-enzyme complex? Okay, can it be true? Complex comprises of condensing, reduction, and releasing units. I already told you that. Enzymes of the reduction unit are dehydratase, ketoacyl reductase, ketoacyl synthase, or thioesterase is the enzyme involved in the release of fatty acids from the complex, or fatty acid synthase complex is functional as a dimer. So what do you think is right? All are true, Gopika? Anyone? Karna may say A, B, D, and E. Okay, you don't think C is right? Okay. So I would give it to Karuna, my beautiful answer. Okay. The only thing that is not right in here is this C. Why? Because C, I told you that this particular enzyme has got 3 roles: condensation, reduction, and releasing. Now, in the reduction unit, there are certain enzymes. Yes, dehydratase is there. Ketoacyl reductase is also there. But ketoacyl synthase is not there. See, synthase is something to do with synthesis. So obviously, in reducting, there cannot be synthase, right? Common sense. Simple, right? So always open up your brain and see. Even if you don't know, synthase word doesn't suit to a reduction unit. So it has to be something. So what is the enzyme in this place? It is enoyl reductase. Instead of these, it is enoyl reductase enzyme, which is present instead of ketoacyl synthase. Okay. So Gopika, just make this small correction that only this option cannot be right, except all of them. Yes, it is a dimer. It has got two things, right? It has got two units that work together. Okay. So all got it, right? Everyone has understood now. Can we move ahead now with the next question? We are soon entering into anatomy. Which of the following water-soluble vitamin is essential as a rate-limiting? This I've already told you. Come on, guys. Now you have to tell me that. I've already told you, whoever is hearing me. Okay. Yes, it is biotin dependent, Karnamai. Very nice. So biotin is an important vitamin that is important as a rate-limiting step in de novo synthesis of fatty acids. Simple as that, right? So this is straightforward. I won't discuss on this. I'll move on to the next question. Yes. Which of the following sources are acetyl-CoA for de novo fatty acid synthesis of fatty acids? So you need acetyl-CoA for fatty acid synthesis, right? And then it will convert to malonyl-CoA. So in getting that acetyl-CoA, you require some resources. So from what all resources you can get acetyl-CoA? This is what the question is. Conversion of pyruvate to acetyl-CoA by pyruvate dehydrogenase complex, you can get it through this. Or you can get it through ketolysis. Or you can get it through beta oxidation of fatty acids, or degradation of carbon skeleton of amino acids, or conversion of pyruvate to lactate by lactate dehydrogenase. What do you think in this particular question? So again, it can be multiple choice correct. So what do you think is right? What all we can say? Karnamai, I think you are very you are very ahead in biochemistry. I love that, because this is one thing I used to struggle with. Right, Janice ma'am? Janice ma'am is there?
Yes, I'm here. I'm here.
They are answering such difficult questions, which I never used to get those answers. Right?
True.
So absolutely right. Janice ma'am, do you want to give an explanation to this particular question?
Yes. So I think one of the option is a complete giveaway. If you can just see, you can easily come to know one of the options actually is the right option, that is conversion of pyruvate to acetyl-CoA. So that would be one of the sources of acetyl-CoA. The other sources, as you can see, what is ketolysis? Anyone?
So ketolysis, anyone? What do you mean by keto and lysis? So that's simple. You can easily make out from this particular term also. See, that is what, get a habit of getting these terminologies. Okay, keto and lysis. Yes, breakdown of ketones. Absolutely.
Yes,
right.
exactly.
Yes.
So when ketone bodies are broken down in the body, we get acetyl-CoA. So this can be also another source of acetyl-CoA. The other one would be beta oxidation of fatty acids.
Right. Janice ma'am, are you there? I think we are not able to hear you. I think there is some problem with the audio. Anna, you are there?
Yes, sir, I'm here.
Yeah, I think there's some audio issues from Janice ma'am's side. Okay,
well,
and yeah.
Okay, no one is answering. Well,
yes.
Yeah, there are certain, you must have heard about amino acids that can be ketogenic or partly glucogenic or ketogenic. So these kind of amino acids, usually when they are metabolized in the body, they give rise to acetyl-CoA. So again, degradation of such type of amino acids again can lead to the formation of acetyl-CoA. And then finally, the last option that you can see here, conversion of pyruvate to lactate by lactate dehydrogenase. Do you remember seeing acetyl-CoA anywhere in the picture? I don't think so.
See? Okay. So smartly you can answer these questions, even if you don't know.
Yes.
Okay, just read the question properly. This is what the correct thing is. Read it. Give it twice a read, because these things might look, oh my god, acetyl-CoA, so many terms are there. They are the easiest because they have got so much information inside. So they will give you the answer inside it only. There's nothing in the last option written related to acetyl-CoA. So obviously it has to be the right answer. Right? Okay, fine. So thank you, Janice ma'am, for the insight. Now we'll move on to the next question. Which of the following sources are of NADPH? So in particularly NADPH is what? It is a reducing agent. You require NADPH a lot, okay, as a reducing agent, and it is used for de novo synthesis of fatty acids. So where does this NADPH come from? What are the sources from which this NADPH is coming from? HMP shunt, Oxidative decarboxylation of malate to pyruvate with the help of malic enzyme, mitochondrial isocitrate dehydrogenase, or conversion of pyruvate to acetyl-CoA with the help of pyruvate dehydrogenase complex. Except D. Karna, you're saying except D. Gopika is saying HMP is not the source for NADPH. Okay. So the Janice ma'am, you want to come in for this?
Yes, sure.
Yes.
So let's have a look at the options once again. Now, NADPH, there are basically three sources of NADPH. Okay, there are three.
I think Janice ma'am, we have lost your voice in this.
Hello?
Yes, yes.
Am I audible now?
Yes, yes, yes.
So HMP shunt, as we all know, it's a part of carbohydrate metabolism. And in there, you get two things. One is pentose sugars and NADPH. So definitely HMP shunt is one of the source of NADPH. The next, yes, I think someone has come up. Yes, C and D are wrong. Okay. So yes, C and D are wrong, but I'll just continue with the right options. The second one that you can see, oxidative decarboxylation of malate to pyruvate. This conversion that helps with the help of occurs with the help of malic enzyme again leads to the formation of NADPH. Now, as Karunamaya has said, it's C and D are incorrect. They are not the sources of NADPH. Let's see why. Karunamaya, could you just
Karunamaya, can you
tell
why C is not correct? Why do you think mitochondrial isocitrate dehydrogenase is not correct? Because this is very close.
So the extra mitochondrial isocitrate
got
dehydrogenase.
it. Absolutely
exactly.
right. So the word extra is missing here. It is extra mitochondrial.
Yes.
Right?
Yes.
So you got the right answer. Great.
True.
See?
So remember everyone, isocitrate dehydrogenase, actually you can find that in the mitochondria as well as outside the mitochondria. So the one that is present in the mitochondria is the same enzyme that participates in TCA cycle, citric acid cycle. Okay, that you can see isocitrate dehydrogenase in one of the steps of TCA cycle. And you know TCA occurs within the mitochondria. So if you see the reaction carefully, there's NADH which is produced and not NADPH. Great. The same enzyme can occur outside the mitochondria, but instead of NADH, you have NADPH which is produced there. And the last step obviously doesn't really generate NADPH at all.
Okay. So now you got the right answers. I think that is self-explanatory. Beautifully explained by Janice ma'am. What exactly are the sources of NADPH? And you can get it in multiple times. This is a very important question also. Right? So A and B are correct. Absolutely, Gopika. A and B are correct. C and D are not correct. Okay. And ma'am has already explained you that why is it not correct. Okay. Now I'll move on to the next. Process of emulsification is favored by. This already ma'am told you. Emulsification with. So how does that? Yes, it's a very straightforward answer. Yes, Gopika, A is the right answer. It is with bile salts. So bile salts help for micelle formation and in emulsification of fats. And phospholipids, peristalsis, bilirubin is not. Okay, one second. Janice ma'am wants to come in.
Yes. So this question has multiple right options. The process of emulsification, yes, true. Bile salts help in the emulsification process, but additionally phospholipids and that whole mechanical mixing of food with the help of peristalsis also helps in the emulsification process. The only exception is bilirubin. Bilirubin doesn't really help with any of the digestive processes that takes place with fat, especially.
Thank you, ma'am. Even I got this wrong because even I went for bile salts. But yes, absolutely, as ma'am corrected you. A, B, and C is right. Okay. Yes. So phospholipids and peristalsis also contribute to this and not bilirubin. Okay. So get this right. The main thing here is not you can get these multiple choices also correct. So this happens in your INI CET exams. Be careful. Okay. In answering, you might get multiple options correct. The more you will tick, the more you will get the right answers. Okay, so be very careful in your answering in these particular questions. Okay, thank you, ma'am, for that. Right, all of the following roles are carried out by bile salts in the digestion and absorption of lipids, except now what does bile salt doesn't do? It helps in emulsification of fat. It enhances the activity of pancreatic lipase, colipase, cholesterol esterase, and phospholipase A2. Helps in mixed micelle formation and helps in activation of lingual lipase. So what it doesn't do? What is this particular bile salts not doing? Okay, Gopika has already answered that it is not helping in the activation of lingual lipase. Can Gopika, you tell me what exactly, what secretes this lingual lipase? And in whom do you find lingual lipase activity the most? So I'll tell you 2 points. Can you answer, Gopika? What glands secrete lingual lipase? A type of gland in that. Ebner's gland. Okay, Ebner's glands. These are the ones which produce this lingual lipase. And in whom do you find lingual lipase activity the highest? So these are a class of subjects where lingual lipase is the maximum and pancreatic lipase is the least. So in which particular age group, I can produce that way, this question, that in which particular age group do you find lingual lipase activity the highest and pancreatic lipase is not very well developed? See, when we become adults, pancreatic lipase activity is very high. But in which category of people do you find lingual lipase activity and gastric lipase activity very high? Which are those candidates? So remember, they are infants. Okay, whenever you get this question, what do infants have the most? Infants have highest gastric lipase and lingual lipase activities. And they have the least pancreatic lipase activity because it is not very well formed or developed. They are still developing in life. So that is why infants have a very high lingual lipase activity, what has been seen, which gradually becomes predominated by pancreatic lipase when we grow older. Okay, that is clean. Okay, everyone understood that? What I told, right? Everyone understood? Can I get a thumbs up for that? If everyone has understood. So infants, lingual lipase and gastric lipase highest. Us or adults, pancreatic lipase is much, much more. Okay, fine. Now I'll move on to the next question. Let's see what the 20th question have. Oh, it's already there. See, so this is the majority of ingested triacyl glycerols are hydrolyzed by lingual and gastric lipase in. Now tell me this answer. Triacyl, exactly. It's absolutely infants. So you understood. So triacyl glycerols are ingested and they are hydrolyzed by maximum lingual and gastric lipase, which is found to be maximum predominated in infants. Okay, not in elderlies. Okay, so this is one of the trick target questions that they give you. Okay, now let me move on to the last 5 questions of today, and they will be towards anatomy. Okay, so let me see how many of you are good with anatomy now. A patient underwent surgical resection of gallbladder. Right subcostal incision was made near the xiphoid process, immediately beneath the costal margin in anterior axillary line, which transected the rectus abdominis and rectus sheath. In simple words, this person is undergoing a gallbladder resection. Gallbladder is in which part of your quadrant of abdomen? Come on. Now you have done quadrants of abdomen. How many quadrants of abdomen are there? Come on, guys. 9 quadrants. Great. Can you tell me what are the 2 lines that are transverse that cut the abdomen? 2 transverse lines. Can you name the lines? Sharon? Okay, Anjali, Dipti, Nidhi, anyone? Yes, transpyloric. Nidhi, correct. Transpyloric, that is basically the first line, that is transpyloric, means that cuts the pylorus into 2 halves. So basically it's transpyloric, that is at the lower level of L1, and transtubercular because it is crossing our iliac tubercles. And then you have got 2 vertical lines, which is from the midpoint of the clavicle, that laterally go down and cut the whole abdomen into 9 quadrants. Okay, now in one of the quadrant, gallbladder surgery is going on. Can anyone tell me what quadrant is the gallbladder in? Anyone? Anyone? Okay, can you name me the quadrants of the abdomen? See, here only I will cover your quadrants of abdomen also, because these things are going to come to you in my future questions. So what are the names of the quadrants of abdomen? Anyone? Right hypochondriac, left hypochondriac, right? Then you have got epigastric in the center. Then you've got right lumbar, left lumbar. You have got, again, umbilical in the center. And below the umbilicus is hypogastrium, and you have got right iliac and left iliac. These are the 9 quadrants of the abdomen. Remember now, right? So your gallbladder is present in your right hypochondriac region. That is just underneath my ribs. This is the area where my gallbladder is, in my right hypochondriac region. So this is the area where I have put a subcostal incision. That is why you will find ribs here, right? So the subcostal incision means, sub means below, the coastal means ribs. We have created an incision, and at the near of the xiphoid process, we have given an incision through the rectus abdominis and rectus sheath, right? In order to do that gallbladder surgery. And this is at the level of transpyloric plane, as Nidhi has rightly said. The anterior wall of the rectus sheath is formed by which of the following? Now, when you read rectus sheath, there are three headings. Rectus sheath, that is present above my costal margin, in between my costal margin, as well as my arcuate line, and below my arcuate line. So these are the three segments where I read my rectus sheath. So what do you think is the lining that I will cut in gallbladder surgery above the level of the costal margin when I'm touching the rectus sheath? Can anyone tell that? What is the anterior wall of the rectus sheath made up of when I'm cutting anything in my abdomen above the level of the costal margin? Anyone? Whether I'm transecting internal oblique and transverse abdominis, or I'm transecting aponeurosis of external oblique and internal oblique, or I'm cutting aponeurosis of external oblique, internal oblique, and all three muscles, or whether I'm cutting fascia transversalis. So basically what I'm cutting, this is what I want to give you. This is very, 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 very important. And I'm going to tell you very small tricks to remember the rectus sheath. Can anyone tell this answer? Because the coming questions are more or less in the same zone. So can anyone tell me what exactly is the rectus sheath anterior wall formed of above the costal margin? Anyone? What is the right answer in here? Anyone? You can write down. Come on. Okay, now let me get back to you in your revision. What exactly forms the rectus sheath? Can you write down on the chat box? Because this is something that has a lot of questions in clinics. Okay, and this is what cesarean surgery you need to understand what you will cut. In gallbladder surgery you need to know what you will cut. In liver surgery you should know what you will cut. So what exactly forms the rectus sheath? First tell me that. Rectus sheath is finished, I think. Can anyone answer on the chat box? Nidhi, can you try? Sharon, Gopika, Karunamai, anyone? Okay, so now let me get things very clear for you. Okay, so you have got a rectus abdominis muscle, right? It is in the center. It is covered by a rectus sheath. Sheath means the fascia that is covering over on the rectus abdominis muscle, right? Okay. Both the sides of my rectus abdominis muscle joins in the center along a line, and that line is called as linea alba. Okay. So this is one rectus, this is another rectus. They are joining together. In the center, there is something called as linea alba. And on the sides, there is another line of my rectus. This side, this is called as linea semilunaris. So you must have seen abs, right? So the linea semilunaris becomes very prominent. Linea alba becomes very prominent. That is why you have got those interdigitations that I've got six-pack. Why? Because laterally there is linea semilunaris, center there is linea alba. Now there is something called as a sheath, right? You must have heard about it. So sheath is formed by external oblique, internal oblique, as well as transversus abdominis going together as aponeurosis and covering it. Okay, right. Now this particular rectus sheath has very important attachments. Remember 2 points. Mark 1 point is above the costal margin. 1 point is costal margin. 1 point is your arcuate line. Now, what is arcuate line? Can anyone tell me what is arcuate line? This is already finished. What is arcuate line? Can anyone tell me? So the rectus muscle, fascia, basically where it is finishing below is called as an arcuate line. So what is that arcuate line called as? It is also called as a fold of Douglas. Okay, arcuate line is called as fold of Douglas. And this particular arcuate line is the lower limit of my rectus sheath, where my lower limit, where my rectus sheath is finishing. That is called as an arcuate line, also called as fold of Douglas, right? This is my lower limit. So there has to be something when I'm transecting out or when I'm cutting out in a gallbladder surgery. What am I cutting? I am cutting out the aponeurosis above the costal margin. And when I'm cutting this aponeurosis above the costal margin, what all things will come in my way? What all things form that rectus sheath? It is formed by what? Now, can anyone tell me? It is formed by the aponeurosis of important two muscles, that is external and internal oblique. I'm going to tell you later on why this happens. But when I'm telling a gallbladder surgery, it is here. I'm cutting only two slips. That is by external and internal oblique. That is it. I'm not cutting anything else. Had I done any surgery below my umbilicus, there I would have got all three aponeuroses together. That is external, internal, and transversus abdominis. So always remember, when I'm cutting lower segments of the abdomen, the rectus sheath will have aponeurosis of all three. But when I'm in the upper segments, they will have external oblique aponeurosis as well as internal oblique aponeurosis. Not more than that. Got the idea? Understood? So when I'm doing a gallbladder surgery, I will cut through aponeurosis of external and internal oblique. This is the answer. Okay? I'll move on to the next things. You'll try to understand more. Okay? Now let me go into the next one. Okay. Young male is presenting with a swelling in the scrotum, perineum, as well as in the penile area after injury to the penile urethra, and there is no extravasation of urine in the thighs. Which of the following anatomical facts supports this finding? So what exactly has happened here? Suppose if there is you are posted in the emergency, okay? You are doctors, you are posted in the emergency, and you have got a patient who has come with a cut injury over on the penile urethra. Okay. Now, you always know when there will be an injury of the penile urethra, the urine will not come out and the urine will start accumulating inside. And when the urine will start accumulating inside, it is not like the urine will go and extravasate into my thighs also. So my body has been beautifully designed so that no urine will go into my thighs if there is a urinary or a penile shaft injury. Now, can anyone tell me why doesn't that urine go into my thigh if there is any injury like this? Why? Out of these four reasons, why is that happening? Is it because of the superficial fatty layer is firmly adherent to the fascia lata at Holden's line? Is it the deep membranous layer of superficial fascia is attached to deep fascia at the thigh? All these are just basic terms, but just tell me why isn't it happening? What is the main thing? Anyone? You understood the question? So there's a person who's come with a penile injury of the urethra. Urethra is the conduit where the urine comes out, and it is injured, a post and road traffic accident, let's say. And now the urine is coming out inside. There is an injury. So the urine is basically flowing inside and is not able to come outside. But still, my urine will not percolate into my thigh region because my body has been designed that way. So this answer, can anyone tell me this answer? Anyone? So the answer to this is because of the Holden's line. This is a very important line. Okay, now let me tell you one important fact. My anterior abdominal wall, when I say, it is having skin, superficial fascia, and then there is muscle, right? When I talk above the umbilicus, I have superficial fascia, which is only a single layer. But when I go below the umbilicus, the superficial fascia splits into two layers. Superficial layer is called as Camper's fascia. Below layer is called as Scarpa. How do you remember? Scarpa is a man who lives under a camp. So remember a camp is outside. So Camper is outside. Scarpa is inside. Camper's fascia is, again, it is more or less fatty. But Scarpa's fascia is membranous. So what I told you? Anterior abdominal wall fascia, when I'm talking about above the umbilicus, it is a single layer. But when I talk about this fascia beneath my umbilicus, that fascia has got two layers. Outer Scarpas, which is outer Campers, which is fatty, inner Scarpas, which is membranous. This membranous layer of my anterior abdominal wall goes down and it merges with the fascia lata of my thigh. My thigh has got a lateral side which is thick, deep fascia. It's a deep fascia condensation called as fascia lata. This fascia of my membranous fascia, or I say my Scarpa's fascia, goes and tightly goes and holds my fascia lata. And that is called as Holden's line. So whenever, because of the attachment of my deep membranous layer of my superficial fascia, what is that called as Scarpa's fascia? When it is attached to the deep fascia of my thigh, which is called as fascia lata, it produces something called as a Holden's line. And because of this, if there is any injury in my perineum or in my penile urethra, that cannot let the urine extravasate into my thigh because it acts as a checkpoint. Understood, everyone? Understood? If that particular same Scarpa's fascia goes into my scrotum, that will be called as dartus fascia. If that fascia, Scarpa's fascia, goes into the penile shaft, it will be called as somebody, have you heard about the fundiform ligament of the penile shaft? So in the penile shaft, it is called as a fundiform ligament of the penile shaft. If that Scarpa's goes into the scrotum, it becomes dartus fascia. If that fascia goes into my thigh, that is called as Holden's line. Simple. So wherever you hear this particular question, why doesn't the urine go? Catch Holden's line. Simple. And it is always the membranous layer or the Scarpa's fascia. Now everyone is fine. Everyone, any doubts on this question? Clear? Right? Everyone is clean? Okay, now let me move on to the next question. You guys would be tired now. Okay, I'm understanding because there's a lot of things. Okay, I'm just finishing my board rounds very fast in 10 minutes. So now again, see, now just think of this. Superficial fascia of anterolateral abdominal wall contains various amount of fat, and below umbilicus, this layer continues to scrotum, perineum, penile shaft, and thighs. I've already told you that. The same thing I've already told you. Which of the following facts are true regarding extension of superficial fascia? Now, I'm not going to read this. You tell me by reading it. What exactly you think? See, deep membranous fascia, when it goes into the perineal region, we call it Colles fascia, or deep membranous layer of superficial fascia in scrotum, and the penile shaft is dartus fascia. Superficial fatty layer of superficial fascia continues into perineal region as Colles fascia, or superficial fatty layer of superficial fascia is firmly attached to fascia lata. Now, can anyone tell me? I've already explained you that. Think this answer. What exactly you think? What exactly is the deep membranous layer of superficial fascia going inferiorly called as? Simple as that. I already told you. When this particular deep membranous layer of the Scarpas goes in the scrotum, we call it what? Come on, write it down. We call it what? What do we call this membranous layer when it goes into the scrotum? Come on. Anyone? Colli. Colli is when it goes into the perineum. Okay. Colles is when it goes into the perineum. When it goes into the scrotum, this is called as dartus fascia. When it goes into the fascia lata, it becomes the Holden's line. When it goes into the penile shaft, it becomes the fundiform ligament of the penile shaft. Understood? So what is the right answer in this? The deep membranous layer of superficial fascia, when it continues inferiorly into the perineum, it is called as Colles fascia. Simple. Why it is called as Colles fascia? Because there was an Irish surgeon. His name was Abraham Coley. So he was the one who got this name. He was the first one who actually got this. Okay. So this is what exactly is the importance. Right? Okay. Sharon, Holden line, other name, I'm not very sure about whether it's called anything else except for the Holden line. But I have read about only the Holden line. If I come across any other term, I'll definitely post it over on the chat box. Okay, Sharon? Right? So this is what the whole concept is. Right? Okay. Now I come to my second last question. I've already told you this. A physical fitness trainer for young Hollywood movie star explains the reason for 100 stomach crunches a day. The young star, a medical student, before hitting it big, reaffirms to his trainer that the lateral margin of the rectus abdominis, the muscle responsible for a washboard stomach means abs, defines which of the following structures. So the lateral margin of the rectus sheath is what? Called as which line? Come on. Which of the line is lateral margin of my rectus sheath? Which will pop out as abs. I already told you. One side of my rectus, linea alba is in the center, Nidhi. So one side rectus, another side rectus in the center, median raphe is linea alba. Linea semilunaris, right, Anjali? So the lateral margins are linea semilunaris. Can anyone tell me what is linea semicircularis? I'll give you an example. Linea semicircularis is also called as fold of Douglas. Linea semicircularis is also given the name as arcuate line. Now you understood what is linea semicircularis, guys. Linea semicircularis. What is arcuate line? Anyone? It is the lower limit of the posterior layer of the rectus sheath, right? Lower limit of the posterior layer of the rectus sheath. The lower limit where it is ending my posterior layer of my rectus sheath is called as linea semicircularis, also called as fold of Douglas, also given the name as arcuate line. Simple. Okay, right? So always remember one thing. I'll tell you very, very frankly. Whenever things are below the arcuate line, posterior part of the rectus sheath is deficient. Whenever we are above that level, posterior layer of the rectus sheath is present. Okay, so whenever I am below the arcuate line is a line with somewhat is present between my umbilicus and my pubis. If I draw an imaginary line, that will be given the name as arcuate line. That is where my posterior end of my rectus sheath finishes. And below that, my rectus abdominis doesn't have anything behind except my fascia transversalis. Nothing else is there behind it. The rectus sheath is deficient below the linea semicircularis or my arcuate line. Okay, so that is what my next question will be towards. In the case of suprapubic, we call it phalansteal incision. That is usually given in cesarean section. Layers of the abdominal wall are incised except what will not be incised? See, suprapubic means a baby is about to come out of the uterus. We have to give an incision that is suprapubic. So I'll cut the anterior abdominal wall. But what will I not cut? What is deficient there? Come on. I just now told you. What is not there? So I told you your rectus sheath posterior wall is finishing at the level of the arcuate line. Below that arcuate line, there is nothing. So if I give a suprapubic incision, what will not be there? What will I not find there? Come on. Will there be anterior wall of rectus sheath present? Will there be posterior wall of rectus sheath present? Will there be transversalis fascia present? Will there be rectus abdominis present? What will not be present in this? Come on, think. What will not be present if I give? Posterior wall of rectus sheath. Simple. Yes, Anjali. Yes, Gopika. Absolutely right. My rectus sheath, always remember this line, just keep it inside your mind. When I go below my arcuate line, that point, my rectus sheath is deficient posteriorly. So I don't have anything else except transversalis fascia. Okay, so there will be my rectus abdominis, and I cut this rectus abdominis, I'll find transversalis fascia, nothing else. And then after that is my straight away my peritoneum. So nothing else in between. But if I go above the arcuate line, that is much above the umbilicus, then I will have a nicely made posterior wall of the rectus sheath, which has got different muscles. I'm not going into that because Matthew sir has already taught you what is the rectus sheath anatomy. It's a huge topic. That's why I don't have that much time. Otherwise, I'll keep sitting with you till 10 o'clock. Okay. So just if you don't remember, go and revise. But remember, below the arcuate line, there is deficient posterior wall of the rectus sheath. So have you guys enjoyed today's word rounds? Okay. I know it is exhaustive. Okay, so these are the previous 25 questions which have been asked in your previous year questions that have been there in your PG. Okay, in various exams, you have collectively told you what exactly it means here, right? So whatever you're not able to answer, go back and think. See, this is the start. This is my first word round. I'm going to come up with multiple. So I've given you a hint today how much prepared you have to come. My idea would be coming here, asking you questions, and you have to be oriented as to what you have read. So try getting that thought inside you. Okay. And we are going to discuss it one-on-one. This is how beautifully it can turn up to be. So I'm really happy that you guys have participated so beautifully today. And you have been able to answer most of the questions right. But whatever were not right, just note it down. You'll get it right in the next part. Okay. So I'm going to grill you till the end. Till this is just a start of marathon. Many more sessions are going to come. Okay. I know you guys must be very hungry and you guys must be very exhausted by now. So I want you guys go eat, refresh yourself, watch a movie, sing a song, or listen to some songs, go play. Okay, this is enough for today. Right? So thank you very much, Anna, for having such a nice participation from the student side. I wish they just keep doing well like this.
Thank you, sir. Thank you so much for the wonderful session.
Yeah, and I thank Janice ma'am also for joining today. Thank you very much, Janice ma'am, for giving us an insight about biochemistry and the important questions that can come. Thank you very much, ma'am.
Thank you so much.
So we are going to end today's session. So keep reading, guys. Keep reading, keep learning, as well as keep earning your Polaris points. You'll soon be upgraded with your leaderboard very soon. Okay. So till then, good night. All the very best to all of you.